you're all set.
Hi, good morning. My name is Larry Kushi. I'm at the Division of Research at Kaiser Permanente, Northern California. And I'd like to thank the organizers of this conference. It's been a great meeting so far, and I look forward to continuing to participate. So my talk will be focused on data collection efforts that may address adverse consequences of cancer treatment from an integrated healthcare system perspective. I don't have any financial conflicts to disclose, and I should say that my views don't necessarily represent those of Kaiser Permanente. Okay. So during this talk, I'll first give a little bit of an overview of what an integrated healthcare delivery system is, some of the unique advantages of why this setting is really a great setting for conducting the type of research that may help to address these adverse consequences. I'll show one example of how these data have been used, and talk about some areas for potential improvement in clinical data. So starting with the integrated healthcare delivery systems overview. So here's a map, of course, of California, and that blue dot just next to San Francisco, actually in downtown Oakland, is where Kaiser Permanente Northern California is headquartered. Now, the service area actually covers much of the Bay Area and the Central Valley of California, from Sacramento down to Fresno. And as I mentioned, KP is an integrated healthcare system. The Northern California region covers about 4.5 million members. The Permanente Medical Group is a large medical group. 21 hospitals that are shown on the map, over 250 outpatient clinics, and there's a single EHR system that connects all of the clinical care provided across all of these entities. I'm part of the Division of Research, which is largely externally funded. Now, the Kaiser Permanente and its Division of Research is actually part of what's called the Healthcare Systems Research Network. And that includes all of these different institutions across the US. The dark states are those where the research groups are headquartered or based. A subset of those were supported through an NCI grant called the Cancer Research Network, which I led for several years. And within the Cancer Research Network, I'll talk about the VDW later, but we developed a common data model called the Virtual Data Warehouse, VDW, which is now implemented across these healthcare systems and all the other systems of Healthcare Systems Research Network. Now, what are the unique advantages of an integrated healthcare system? All the HCSRN members are integrated in some fashion or another. Now, basically, an integrated healthcare system implies that most of the medical care that a person may receive is obtained within that healthcare system. And so that includes both, sort of primary care as well as specialty care. The membership is largely representative of the community. So these are community-based healthcare systems. Because both these systems are both the insurer and the provider of care, there are defined membership populations that we can identify who have essentially received all or most of their care within the system, and they're very high retention rates. And of course, we have longstanding electronic health records that date back at least 15 years in most cases, and substantially farther in some certain clinical domains. And it's not just claims data, but the details of care, that's obtainable from electronic health records. As I mentioned, we have, for research purposes, created this common data model called the Virtual Data Warehouse. And because our research groups are actually part of these healthcare systems, then we have direct collaboration with providers, or at least the opportunity for doing so, and really supporting a learning healthcare system. So just a little bit more on that. As I mentioned, an integrated healthcare system basically provides care across the whole spectrum of care that people may receive. So in the context of cancer, primary care, preventive services, cancer screening, cancer treatment, oncology, et cetera, surveillance afterwards, palliative care, and hospice. And importantly, these systems provide care not just for cancer, but for other conditions such as cardiology, et cetera. So we know that it's possible. I mean, we can track cardiac events in the same EHR as we can the oncology-related services. And KP Northern California and many of our CRN partners are largely closed systems with essentially all care provided by Kaiser Permanente. And this differs substantially from many academic health centers and NCI-designated cancer centers, where you don't get a comprehensive view of clinical care. These are often referral or tertiary care centers, so there's very little information on cancer screening for the patients who are actually treated there, unless it's actually explicitly recorded. And also after people are treated actively, then they may go back to their community settings, and so there's limited information on follow-up care and other specialty care that an academic health center may have, such as in cardiology. They may not be treating the same patient population as those who are seen by the cancer treatment folks. So the integrated healthcare setting really provides the opportunity to link all those things. Now, in terms of retention, this is a table demonstrating the number of years after diagnosis in terms of the proportion of the population who are still receiving care and are still members of the different healthcare systems. And so each of these are members of the Cancer Research Network. And as you can see, 5 years out, 80% or perhaps more, and even 10 years out, the substantial portion of the population continues to be members after cancer diagnosis. Now, this is KP Northern California, and I should point out that, of course, this includes people who do pass away when they are members. Just to show this graphically, the dark blue bars are those people who have been continuously enrolled and are still alive. So, whereas light blue bars are those who are continuously enrolled until they passed away after cancer. Of course, many cancers are rapidly fatal. And then the more orangish bars are those who disenrolled from Kaiser Northern California. So as you can see, 10 years out, over 80% of the population of people with cancer, we can capture essentially all clinical information that's documented within the EHR and associated databases. Even 20 years out, 19 years out, it's almost 80%. So we have the ability to really look at a wide variety of adverse consequences that are documented in clinical data systems. Now, in order to actually use those data for research purposes, we created what's called the virtual data warehouse. And as I mentioned, this is implemented across the HCSRN. Database in our database on a monthly or quarterly or semi-annually basis. So not to go into the details here, but for example, in our VDW, which dates back to information back to 1996 for essentially the complete membership, there's about 17 million total individuals, almost 1.9 billion diagnoses, 1.4 billion procedures, et cetera. And when we think about adverse outcomes, then many of these data domains are areas that can capture these. So diagnoses, procedures, death or cause of death, the tumor registry for second primary cancers, and now recurrences more recently. Laboratory results for things like neutropenia, pharmacy, prescription medications for different conditions, and in select areas, patient-reported outcomes, such as there's a depression scale that's often given to cancer patients. These are some other various areas that are part of the VDW, but among those include, for example, the infusion medications in which we capture details of chemotherapy, the drugs and the dosages received, dates of administration, oral medications through pharmacy, tumor registry, captures the SEER level type information, and of course procedures such as surgical procedures. And there are various other domains as well. I won't go into those. So I'll give you one example. I was originally going to provide a couple, but I'll provide one example specifically of comparison of real world to clinical trials experience. And as we generally know, most clinical trial participants are highly selected. They tend to be relatively healthy, few comorbidities, younger than the general patient population when we're talking about adult cancer trials. So this is a paper that we published out of the Cancer Research Network, published in JNCI a number of years ago, basically looking at the risk of heart failure in breast cancer patients after treatment with cardiotoxic agents. And basically, this is the bottom line. The typical RCTs that have published in this area have demonstrated over a 5-year period something like a 2 to 4% heart failure rate. And this is for people aged 75 or older in this particular graph. But as you can see, the cumulative occurrence of heart failure is substantially higher, and it certainly is impacted by the type of therapy as well, versus those who didn't receive any of those. But as you can see, the real world experience it can be substantially different from what you see in RCTs, depending on age group and presence of other conditions. So thinking about the type of data that are available and where there could potentially be improvements, just a couple of things to mention: that some areas are not well documented or have limitations in terms of timeliness of availability of the information if we really want to be able to act on information in a rapid fashion. So cancer diagnosis, for example, that's routinely available in much detail in cancer registries, and we have an internal one. But information even such as stage is not otherwise well documented. And so not really available in real time, even though it's used clinically, obviously, for treatment. Molecular markers, a rapidly evolving area, and structured information on whether tests were performed, and what the test results are often not available. They may be available clinically in PDF documents, but they're not available in a structured format. Performance status, routinely available in clinical trial settings, but rarely documented in clinical care. Radiation therapy, the details of the treatment data are available in databases that are not linked to the EHR and not readily accessible. Recurrence or progression is not documented in a routine fashion. And death and cause of death, again, that's mostly a timeliness issue, since that information has to come from linkage with other vital statistics sources in order to be complete, not just from internal health system sources. And as I mentioned earlier, patient-reported exposures and outcomes are really pretty limited, and there's really an opportunity to really expand that domain. So the effective use of electronic healthcare data can generate knowledge to improve health, and these data are indeed widely available now, and they're relatively easy to obtain, but they're really difficult to use well, and one could easily get the wrong answer, which might result in potential for harm. And just a couple of things to note: these data are not collected for research or analytic purposes. They're collected for clinical or administrative purposes, such as billing. And people who have data, who have come in for a visit, are often systematically different from people who do not. And so really thinking about how you interpret the information that's available is a really key part of really using these data. Despite these limitations and the cautions on interpretation, the integrated healthcare setting really provides the opportunity to really advance knowledge on adverse outcomes related to cancer treatment. So thanks very much.